Good morning, ASIP. Welcome to our annual meeting. This is a great city to have a meeting and to spend time with your family. Take them to all the museums, all the monuments, and teach them a lesson about our forefathers and what they had in mind when they drafted the Constitution. Okay, it's we the people. And that's the most important message when you leave this town. All right, so history never looks like history when you're living through it. It always looks confusing, messy, and it always feels uncomfortable. Doesn't that reflect on the state of health providers, and especially the interventional pain physicians in this time and age? That is what we are facing. Now, it's up to you how to approach this. You can either give up and automatically be transferred on the menu, or you can decide to look at this as an opportunity and move ahead and sit at the table. We at ASIP have chosen to sit at the table and participate and look at these things as an opportunity that we can come together and help reshape our future. That's our goal. The Dr. Manchikanti Distinguished Lecture was recommended by Dr. David Cloth, one of our past presidents, in 2005. In honor of all LACS has done for our specialty. I call him the new father of interventional pain management. And in the past, we have always had certain physicians who have contributed to our field tremendously, like Dr. Rags, Dr. Stanton Hicks, Dr. Bogdock, Dr. Rosen, Dr. Pearson, Dr. Rick Derby. So they have been our speakers. This year, because of certain circumstances of being faced with a massive healthcare reform and a lot of uncertainties surrounding it, we have invited a health policy expert to be our distinguished speaker, and he's David Merritt. So this is Dr. Manchikanti summarized in one statement. And every time you talk to him, you know, he will not be very impressed with what you say, but he will be very impressed by your hard work and perseverance in following up on projects. But no matter who, nobody can catch him because he's just like an Energizer bunny, and he keeps going and going. How he does it, it's a mystery to all of us, but we can't figure it out, and we can never match it. That's a known fact, so we cannot match him. He's a true believer in what John F. Kennedy said, that ask not what your country can do for you, ask what you can do for your country. And also a firm believer in what Ronald Reagan said, that there is no limit to what a man can do or where he can go if he doesn't mind who gets the credit. And he thinks that the only thing you can take with you when you die is what you give to others. And his life reflects that, whether professionally in medicine or in his personal life. That I will give you a little summary of that. So some of his achievements, I'm going to mention them. I have to, because they are crucial to our existence. He founded ASIP in 1998, and he picked these 4 pillars as the founding principles of this organization. He wanted to preserve interventional pain management. That was the reason why ASIP was founded. He focused on education, research. He embraced the innovation and new treatments. And a major focus of this society has always been fighting fraud and abuse and promoting compliance. And that is reflected in our board certification. That's a requirement to be board certified in interventional pain. He also founded Society of Interventional Pain Management Surgery Centers. That's goal is to, the main goal is to preserve access to the patients in surgery centers to interventional pain procedure. And he does that through advocacy and preserving that access. Now, one of the other things that have been very actively pursued since the beginning is the PAC. And that is comprised of legislative initiatives, Capitol Hill visits, lobbying, and having a presence at the table. And the table is in Washington, D.C. And that's where we have a continuous presence. And let me tell you this. Monday, Tuesday, Wednesday, we're all going to go to the Hill together, and you will be very impressed by the lineup of all the congressmen and women who are going to come talk to us, or we're going to go meet with them. And they all know our organization because we have persevered year after year. We have always shown up this time of the year, despite some of the legislative branches not being in session, but they have come to visit with us and address our concerns. So, and that's only one way that ACIP promotes advocacy. There's other ways that we as members can do it through the letters that we send to our congressmen and women, and also unofficial, unscheduled visits that ACIP leadership does throughout the year. So this is our mission statement: to promote the development and practice of safe, high-quality, cost-effective interventional pain medicine techniques for the diagnosis and treatment of pain and related disorders, and to ensure patient access to these interventions. Remember now, when you go to meet with the politicians, you always focus on your demand that patients need to maintain their access to these treatments. So that's the key, that's the buzzword, access, okay? The NUC definition of interventional pain management is here. As you see, it says, no offense to non-physicians, but this is the discipline of medicine devoted to the diagnosis and treatment of pain-related disorders, principally with the application of interventional techniques independently or in conjunction with other modalities of treatments. We are probably the most comprehensive pain management organization that we teach and we promote, we issue guidelines, reviews on pain, from treating pain from head to toe, and with or without needles. That's the definition of comprehensive pain management. That doesn't mean that we exclude those who decide to just use the needle or just treat the spine, but our society embraces all who treat pain in a comprehensive fashion. And what is interventional techniques? There's a definition, and that was from a MedPAC report in 2001. Use all these whenever you're meeting with the officials or the leaders of your hospital. Always try to use these definitions so that they have better understanding. Well, a lot of things they said when ACIP was formed in 1998, most of the pundits claimed that none of this could be achieved. But a lot of those impossibles have become a reality. So when you look back, you see that, wow, in 2005, we got interventional pain management, a specialty code by CMS. Those of you who have not changed their specialty code to 09 and are practicing more than 50% of the time in interventional pain, you need to do that. So that happened in 2005. And that was yours. And then interventional pain management, this was the biggest thing that happened at that time, became the 34th specialty to have a chair at the carrier advisory committees. That's huge. So we had a seat at the table again. That's the whole concept. And this was the transmittal that talked about the pain management. There is also another code, if you know, about chronic pain management, which is 72. All right. One of the crown jewels of this society is our journal. I think every member of editorial board should be proud of having a journal with an index factor of 7.793. This is higher than anesthesiology, neurosurgery, pain medicine, any pain-related specialty journal. This has the highest impact factor. This is on PubMed. You can have all the articles free on ACIP's website. And if you have a nice article, a nice research, you want it published fast, we promise that our journal has one of the fastest turnovers as far as getting the articles reviewed and published. So some people complain that Dr. Manchikanti's most of these publications, or most of the publications in the past in the journal were by Dr. Manchikanti. And they raise this issue and they think that's a weakness. In our opinion, that's a sign of strength and putting money where your mouth is. Okay? We support, this is our specialty and we like to support it, and this is our journal, this is our voice. So that's what we would like to support. NASPR. NASPR has been signed into a law since 2005, I believe. And unfortunately, the funding has been an issue, and that will be one of the legislative actions that we will pursue during our visit to the Hill. Okay. In the process, we have also grown up and become a society member at AMA. So we are at all those good old boys club, RUC committee, CPT committee. We have a presence, we have a representative in all of those. We work tirelessly on the reimbursement issues. Every time there is an issue with reimbursement or a policy change, ACIP will be a leader in addressing those. And please, if you come across any policy change, write a letter and we will pursue it. On the website, that's one of your resources. On the website, there is a copy or a sample of letters that has been sent to different insurers, different policymakers, and you can use those to address your reimbursement problems. We always believe one of the best ways to address the quality of patient care is to create a board certification. That has been one of our goals. It's not ABMS member yet, but hopefully in the future we can work on that. So if you have not taken the American Board of Interventional Pain Physicians, I encourage you to get in the process of the examination. It's probably one of the most comprehensive, not one of them, is the only comprehensive interventional pain exam that is out there. As you know, our guidelines have been updated every 2 years. This year we're a little bit behind, but you will get an updated guidelines on opioids and also spinal interventions. On the educational side, we have our review courses and specialty cadaver workshops. And one of the things that Dr. Cloth here has been a big advocate and leader in it has been the PR campaign. And you will see a lot of activities in the future about that. Okay, so who is Dr. Manchikanti? The new father of interventional pain management. He's board certified in pain medicine and American Board of Interventional Pain Physician. He's the chairman of the board and CEO of ACIP and SIPMS. People say, how could a medical society have a CEO? Well, that's exactly why it's the most efficient one, because that's how you run a business. ACIP is run like a business, like a successful business. And that's his position. He's the medical director at the Pain Management Centers of Paducah and the ASC, and he's a clinical professor of anesthesiology and perioperative medicine at the University of Louisville, Kentucky. He's a member of Kentucky CAC, AMA. He's been AMA delegate, served on the Board of Regents of Murray State University in Kentucky, Kentucky Board of Medical Licensure, and MCAC. So he's one of the most active people in our field. And at the same time, he has dedicated his life in also publishing books that is going to help maintain the quality of interventional pain. He has so far published 8 books, and there is a new book in progress. You will see a sample of it up front. There is over 300 peer-reviewed publications from him, and most importantly, he has run a lot of randomized trials on his own budget without taking any contribution from industry. And he is the author of many systematic reviews, all the guidelines, and this is the new book that's Essentials of Practice Management about billing, coding, and compliance. These are the books that should be essential to any practice. The foundations, clinical aspects, and the board review assessment, they were published 2 years ago. And I love these books. They come with a CD that you can export all the tables, all the data, all the pictures into your presentation if you're preparing a presentation. So that's one side of Lags. Thank you. There is another side of him that he rarely talks about it, and many people don't even know about it. And he's created scholarships, schools, colleges, temples, and many other things in his homeland. That's what they wrote about him in India. He is a graduate of the Gandhi Medical College in Osmania University in Hyderabad. I know how to say that. He remains very close to his hometown of Budangparti in India, and to improve the education opportunities for children in India, he built a high school, and He also attended the inauguration of a new junior college that he has supported, and he also built a temple in his hometown. And also, as you see, that's the Alumni Education Center at the Gandhi Medical College that he built there. This is the high school, and that's the statue of his grandmother in the front. This is the college, and that is the temple. Maybe we should do the annual meeting one year in your hometown, Lax. Before we go any further, I would like to remind you that we have a fundraiser on Monday evening. Please come join us. You know, even if you make the smallest contribution, it does make a change. Congressman Whitfield has been a greatest supporter of interventional pain throughout the last decade. Now, our speaker is David Merrit. He is a nationally recognized expert on health policy and health transformation, and he is a former CEO of the Center for Health Transformation. He has worked as a consultant to several politicians like Newt Gingrich, Senator Fred Thompson, Senator John McCain, and he is the editor of an award-winning book called Paper Kills and its sequel, Paper Kills 2.0. And he is a senior advisor at Leavitt Partners in Washington, D.C. Michael Leavitt was the former Health and Human Services Secretary and former governor of Utah. And I was told by Lax that now he will head the transformation team on healthcare for Mitt Romney. Am I correct, David? So without any further ado, to answer a lot of your questions and dilemmas, here is David Merrit speaking about the health reform.
All right, well, good morning. It's great to be here. Thank you to ACIP for having me. I was a little embarrassed, I do have to admit, when I saw that list of past speakers for this particular lecture. There were a lot of MDs there. You noticed it was conspicuous that there was no MD behind my name. And I actually get a little nervous talking with docs and providers because you know healthcare so well. You're really the front line. You're healthcare personified. It reminds me of a story of, there was a Johnstown floods. Anyone remember hearing about the Johnstown floods? This is in the late 1800s in Pennsylvania, and it was a huge flood. Up until then, up until recently actually, it was the worst natural disaster in American history. It killed 3,000 people. And so this gentleman survived the Johnstown floods. Harrowing tale, loved to tell people about it. So he spent many years talking about it, and he finally died. He gets up to heaven, and St. Peter asks him, is there something we can do for you? Can we make your stay more comfortable? And this gentleman said, yeah, I would actually like to talk about my experience surviving the Johnstown floods. And St. Peter said, great, well, let me make arrangements, which he did, and he came back and he told this gentleman, hey, good news. I set up assembly for you on cloud C3 tomorrow at 9 o'clock to talk about your experience surviving the floods. He said, but I do want to tell you, there is one catch. Noah is going to be in the audience. And I thought, okay, wait a second. I'm going to be talking about healthcare to a group of 400 doctors. Gotcha. But when we're talking about politics and policy and how that relates to what you do every day, I'm on a little firmer ground. And since we're in D.C., you could probably, and you probably landed in Reagan, you could probably smell the dysfunction when you got off the plane, right, here in D.C. But it has been an interesting couple of years. It's going to be another interesting few weeks as we try and look into our crystal balls about what the Supreme Court is actually going to decide in the next few weeks on the fate of the health reform bill. So what we're going to cover this morning are a few updates on health reform, what's actually been implemented, what's on track to be implemented this year, what's coming down the pike in the coming years. Because one of the scenarios, obviously, is that the Supreme Court will uphold it, the president will be reelected, and health reform will be the law of the land for the foreseeable future. So knowing what it is certainly important. Also, what is the Supreme Court actually reviewing? What are some of the possibilities that they may decide upon? The individual mandate, the requirement to purchase insurance, there are other issues. But there are lots of scenarios on how they may decide that could certainly impact everyone. Also, the elections. You can't come to Washington, D.C. and not talk about politics. And 5 months from now, we are going to have an election. And just to clarify what the doctor said, Mike Leavitt is heading the transition team for Governor Romney. So he's going to be doing a lot of planning on political appointees and regulatory review and everything. So he certainly has a big job ahead of him. But lastly, to look ahead to next year and what may happen, given what the Supreme Court could rule and given what the elections may bring us, 2013 could be a very interesting year, or it could be a continuation of the status quo. So those are the four big areas we'll cover this morning, and I really do want to, at the end, open it up to a dialogue. So if you have questions, concerns, clarifications, I'm happy to answer them. But as I said, starting off with what health reform actually is, I'm sure you've read lots and lots about it. It's been the law of the land for a little more than 2 years. But just to recap really what it is, it's a very interesting slide here. And even though it is true I helped Senator McCain in his presidential run, I hesitate to call Fred Thompson's effort a campaign, but I did help him, and I spent many years with Newt Gingrich, both as president and CEO of his organization, the Center for Health Transformation, but also as a campaign advisor. And we actually put this together about 2 years ago. We actually printed this thing out, and our team went through the bill, 2,700 pages, and plotted out a timeline. Okay, so we printed this, and in all its glory, it's 10 feet wide by 5 feet high. And we had to make it that large. These little boxes represent every deadline, every requirement, every provision in the law. Some are very minor, others are quite big. But we had to make it this large to fit it all on one single sheet. And what it shows you is every year what the law actually is. So there are nearly 500 of these deadlines. And as I said, some are very small, some is just a report that Congress needs to authorize. Others are like the individual mandate, that's one box on here. Or the state insurance exchanges that open in 2014. That's one box, but these things have thousands and thousands of pages of regulation behind them. So each box represents a huge, huge initiative. But this tells you between 2010 and over the next decade how massive this law is, what impact it will have on the delivery of care, on the covering of care through insurance, and ultimately on what patients access. So just to keep this in mind, it is certainly very, very complex. And just to give you a sense of what some of these things are, as I mentioned, a few of them go into delivery reforms, there's transparency, there's employer reporting, there are mandates and penalties, things on physician-owned hospitals, new taxes, new reports. If you're interested, this is still available. And it does make a nice centerpiece for your living room if you're looking for some nice artwork. There's also another aspect to it, and this actually, I was reminded of this by talking with Lax about single dose files. So we put together another 5 by 10 wall chart, and this one showed every power that the Secretary of Health and Human Services was given or expanded under the health reform law. One person has almost 2,000 new and expanded powers. So we went through every power, and so these are all small boxes, and They're organized by section of the bill. Some of these, again, fairly minor, others fairly major. Here's a sample of them. My favorite is down on the bottom, the National Health and Nutrition Examination Survey. The Secretary shall develop oral health care components that shall include tooth-level surveillance for inclusion in the National Health and Nutrition Examination Survey. The term tooth-level surveillance means a clinical examination where an examiner looks at each dental surface on each tooth in the mouth, and as expanded by the Division of Oral Health and Centers for Disease Control. Does this sound a little minute and a little too in the weeds for one person who was appointed by the president? I mean, in my mind, I would rather have dentists determining how to examine teeth. And just like the CDC and CMS determining how you administer medication, about how you have to use one vial and waste waste 95% of the dose. It's that level of minutia that the bill often has. So it certainly hits every corner of the industry. But just to review a few of these, and I'm not going to go through all of them, you have the slides in your material. But just to review a few of them, because there have been some significant provisions implemented thus far, though 2014, as you'll see, is the really important year. So the clock is certainly ticking until we get to some of the more well-known provisions. But there have been some changes to the way insurance is provided. Insurers now need to cover certain provisions, certain preventative services free of charge. There are some practices like rescissions that have been prohibited, as well as coverage limits and caps. And the last bullet, that's one of the more popular ones, adult children. That's a quote from the law. Adult children can remain on their parents' health plans until age 26. Though here in DC, that's known as the slacker provision, which many recent grads have come to enjoy. There are several annual fees that have been assessed on industries. The one so far that's been actually implemented is on pharmaceutical manufacturers. As an industry, they pay a couple of $1 billion a year. Insurers, as you'll see, beginning in 2014, have an insurance industry fee of $60 billion. This is literally just a fee on insurance to pull revenue out of the industry and pay for many of the things that are in the law, from the subsidies to the Medicaid expansion and many others. Medical loss ratio was actually a big, big issue back in 2010. And this basically tells insurance companies how to spend their money. So they all receive premium dollars from us as we pay premiums for our insurance. And medical loss ratio dictates that between 80 and 85% of those premium dollars collected have to go to actual medical care. The smaller bucket, between 15 and 20%, can be used on other things. Marketing, overhead, salaries, benefits, profits, you name it. That's administrative. So determining what fell into each bucket, whether fraud and abuse or fraud detection was administrative or clinical, whether electronic medical records were clinical or administrative was a big battle. But it just gets to the point where this law actually gets into the game of telling an industry how to spend its revenue, which is unprecedented. New tax went into effect this year. Two things that that HHS has done that's actually been, I think, fairly surprising for many is how they've actually deferred to the states to implement much of the law. There are cries that this is a federal takeover, and it certainly expands the federal role, but they've been fairly deferential when it comes to setting up these insurance exchanges where consumers will go through to find their options for insurance beginning in 2014, and also defining in each state what constitutes essential health benefits. It's basically the minimum package of benefits that every health insurance policy has to cover. Instead of doing that at the national level, leaving it to states to determine for each state. And don't forget about the 10% tax on indoor tanning services. I always find that one so strange because you have to think this bill cost more than $1 trillion, and it just shows you that they were literally looking through the couch cushions on Capitol Hill to find any money that they could find, that they implemented a 10% tax on indoor tanning services, only in Washington. But there are some quality-related provisions. Let's face it, I think most of the law was focused on expanding coverage. Very little was done on cost containment, cost control. Some was done on quality, and I think they can plant some seeds that actually could pay dividends over the years. But I wouldn't call it a high priority in the law. But there are many programs that they implemented. Value-based purchasing is something that Secretary Leavitt placed a high priority on when he was there. They try and equalize and incentivize primary care physicians. The one that, on this list at least, that has received the most news coverage has been the bottom one. And I notice you have a session or a luncheon on that tomorrow around the Accountable Care Organization demonstration project. And this basically tries to incentivize physicians to better coordinate care among community providers. There are lots of reimbursement cuts. There are changes to payment. There's bundle payment pilots where they pay for an episode of care rather than each individual piece of it. There is a physician compare website. Everyone is probably aware of hospital compare, but coming next year there is physician compare, which should scare the bejesus out of many of you if you're a physician, where over time they're going to be adding more and more quality outcomes and quality measures that consumers can actually see. I think starting next year it'll probably be fairly elementary information, but over time that will grow where consumers will have more information on the performance and cost of physicians. So 2014, as I mentioned, is the big year. That's when coverage for pre-existing conditions comes online. That's when the subsidies are available. That's when Medicaid is expanded. That's when community rating for premium determination comes online. And two of those are provisions that we'll focus on when we talk about the Supreme Court, the pre-existing conditions and community ratings. Also note that in 2014, there is a federal cap on what individuals can spend on health care. So no longer can we spend more than almost 10% of our income out of pocket. So very important year, 2014. There are also pay cuts. That's when the industry fee on insurers comes online. That's when Medicaid's expanded. And this last one is one that I think folks have overlooked to some degree, and that is that employers, beginning in 2014, are required to provide qualified coverage determined by the government, or they will pay a fine per employee, between $2,000 and $3,000 per employee. And this is important because employers are not mandated to do it. Like the individual mandate says, we have to do it or pay a fine or a tax. Here, you can have a choice whether you want to offer qualified benefits or not, but if you don't, you're going to pay between $2,000 and $3,000 per employee. So you think of a company like Verizon, you think of AT&T, Coca-Cola, huge companies. If they have one person that is eligible for a subsidy and goes out and actually uses that subsidy, every employee will be, or for every employee, they'll be fined between $2,000 and $3,000. Some of these companies have 200,000, 300,000 employees. There was actually a hearing a couple of years ago, I think it was in 2010, when the House Energy and Commerce Committee was looking at this, and AT&T had already been running the numbers. How much do we spend annually on health benefits? And it was about $4.7 billion for nearly 200,000 employees. They ran the math and said, okay, let's multiply our employees times 2,000 and see what we come up with. It was about $1 billion. So if they decided to get out of offering coverage, they would save themselves almost $4 billion a year. So AT&T probably wouldn't get out of the business of offering coverage. But you think of smaller employees, you think of somebody who has 51 employees, do you think there's going to be any games for them to play to get under that threshold? You know, it's kind of an arbitrary threshold, it seems to me. But that's going to be a huge, huge issue because they are basically incentivized to get out of the business of providing health benefits, which is, you know, up until now, we've had an employer-sponsored system. So that could be a very, very big issue if the law is still in place beginning in 2014, because people will now have a place to go. That's been one of the things that's held back businesses. There is no place for their employees to go if they don't offer coverage. Now they have subsidies, they have Medicaid, they can get insurance because they can't be denied for pre-existing conditions. Their premiums will be fairly low because they'll be rated across the community and not underwritten based upon an individual. So there is a place to go. So employers are going to have that incentive to actually get out of that business, which would be a fundamental change from what we've seen in the last 60 years. All right. So that's what's at stake. That's what's at stake here before the Supreme Court. And when the lawsuits were filed shortly after passage of the law, or the signing of the law, many folks thought, there's nothing to this. You know, these are just conservatives run amok. They're just fighting this because they don't like it. And to a certain degree, that's probably true. But there are also legal reasons why lawsuits were filed against the law. So there were 4 things that the Supreme Court heard in oral arguments about 2 months ago. And they actually had longer oral arguments on this issue than they've had on any case in the last 100 years. So this tells you how important even the Supreme Court understands that this is a critically important issue facing our country. So they looked at 4 things. First is something called the Anti-Injunction Act. And I see someone yawning, and it's tax law, so I would be yawning too. But the Anti-Injunction Act basically said, is there standing for someone to sue because they've been injured by the individual mandate? It hasn't actually been implemented yet. So the Anti-Injunction Act says you can't sue until you've been injured. And the injury, which would be a form of a tax payment, won't actually happen until 2015. Because in 2014, you're required to purchase the insurance. If you don't do it in 2014, you will pay a tax penalty in 2015. Both sides have basically said, you have standing, the court has standing to rule on this now. So that one really isn't an issue. No one expects it to be an issue that comes up in the next couple weeks. Medicaid expansion. I'll bet you most folks don't know that between the 10 and 20 million Americans, of the 35 soon-to-be newly insured Americans, will actually be insured through Medicaid. Medicaid, as you probably know, is a broken system. As a physician, you probably realize that how many of you actually see Medicaid patients and accept Medicaid? More than I thought, actually. The rates for Medicaid reimbursement are about 60% of commercial rates. It's been a problem for a long time. Access to Medicaid benefits are fantastic, but actually finding physicians and facilities that take it has been a chronic problem for those on the program. But the law actually expands Medicaid up for 20 million Americans. So states can no longer play with the eligibility as they see fit. It's actually raised federal minimum of 133% of the federal poverty rate. Anyone is eligible for it. So they didn't do anything to help with access. They didn't do anything to help with the number of providers. Reimbursement, I guess, was bumped a little bit temporarily. But still, 20 million Americans are going to be on Medicaid. States have actually sued because they say it's been a federal-state partnership for so long that this expansion dramatically changes the dynamic between state autonomy and flexibility and federal administration of the program. And that it shifts the balance so much that states are now being coerced into participating in Medicaid. Again, most legal scholars think that this issue will not be supported by the court. They think it's been longstanding law that Medicaid is legal and that states have a choice whether to participate in it or not. Some states have actually talked about getting out of Medicaid, Texas being the most prominent. But most court watchers say that this one will not be accepted by the court. So that leaves us with the two that we should focus on this morning, which are the individual mandate and what's called severability. And severability is basically whether the mandate can be ruled unconstitutional and the rest of the law remain in place. So we'll just go through the mandate. Question comes down, in its essence, is can the federal government require individuals to purchase government-approved insurance? Can the government require individuals to buy government-approved insurance? Up until now, consumers, citizens, we haven't been forced to buy anything. States certainly have had mandates. We've seen the most prominent being Massachusetts with its individual mandate for health insurance. But you think of homeowners insurance, auto insurance, there are lots of mandates that are all at the state level. Does the federal government have that same power? The states that sued said no. Said this asserted power does not exist in constitutional law. And it would be a revolution between the relationship of government and the governed. It's been a split decision thus far between that perspective and the government's perspective, which says yes, the Constitution gives the Congress to regulate interstate commerce. And healthcare certainly is, falls into the category of being an interstate activity. And it has the power to levy and collect taxes. So between those two constitutional powers, the government is asserting the right to require us to purchase a product. And as I said, it's been a split decision thus far. There have been some federal courts that have said, yes, the government has this power. There have been a couple that have said, no, the Congress does not have this power. And that's where we're at, actually. That's what has bubbled up to the Supreme Court, or is the difference between those rulings in the lower courts. And it is interesting, because you have to think, we haven't been required, and folks really wonder, where is the end? And I think that's where the states have come from, and some of the questions that we heard in oral arguments, the stinging questions from the conservatives. Where is the end of the commerce power, of the Commerce Clause, and the power of Congress through the Commerce Clause? If it doesn't end with requiring us to buy something, where does it end? You know, the most prominent quip is that, you know, if they can require us to buy insurance, they can require us to eat broccoli. And you do have to think, you know, you look at trend lines for population health, they're terrible. I think the last thing I heard was in every state in the country, 30% of the population is now obese, according to the CDC. Childhood obesity has tripled since 1980. So you wonder, well, if they can require us to do this, can they require us to do something else? Maybe. Now, one of the things that the government actually is pointing to is a case from the New Deal era. In 1937, there was a case filed by a farmer who violated an act of Congress that said, you will only produce X amount of wheat. They put caps on wheat production to try and increase the demand and lower the supply, to keep wheat prices up. So this farmer produced above the quota. And he was sanctioned by the Agriculture Department, and he ended up filing suit, saying, I can produce it. I have the right to produce this on my farm. I'm not actually going to produce this for the marketplace. I'm going to use it for my own personal consumption and my family's personal consumption. Back then, the Supreme Court actually ruled that the government had the right to force him to destroy the extra wheat that he had produced, even though he wasn't going to put it into the marketplace. And they justified that because of their power to regulate interstate commerce. But the interesting thing was, they were regulating an activity. So he had produced the wheat, and they were telling him that he could not use it. He had to destroy it, because his activity actually influenced somehow the rest of the marketplace. In this case, the states point to that same precedent and say, wait a second, you're actually requiring someone to do something. Because if you don't purchase insurance, that's an inactivity. How can you regulate inactivity as interstate commerce? Commerce means you're doing something. When you don't purchase insurance, you're not doing something. So that's what really comes down to at the court for the constitutionality of the individual mandate. Interesting stuff. Severability is not quite as interesting, but it's certainly as important. And what severability basically says, if the court finds that the individual mandate is unconstitutional, can the rest of the law function without it? Is the mandate severable from the rest of the law? The government says, yes, it is severable. That means you can take a piece of the law and rule it unconstitutional, but the rest of the law can stand. The states say, no, the mandate is necessary to make all of those other provisions work. Now, I would not go that far to say the mandate makes every provision work. Do you think the mandate makes that tooth-level surveillance provision work? Probably not. Does it make ACOs work? No. But does it make a lot of the insurance provisions work? Absolutely. Absolutely. It's basically, I've heard a great analogy, that it's like wheels in a clock. And the individual mandate is like the biggest cog in that wheel. And you have a couple of other ones that have to work along with it. So if the mandate is there and it's turning lots of other pieces. A couple of the most important, and I mentioned them before, are what's called guaranteed issue and community rating. And that's what the government says. They say basically on severability, yes, the mandate is severable, but community rating and guaranteed issue are so integral to the mandate that those two have to go if the mandate is declared unconstitutional. Now those two provisions, guaranteed issue basically says, requires insurance companies to cover individuals with pre-existing conditions in the individual and small group insurance markets. So now if an individual wants an individual policy, they're underwritten based on their own health status, their own health history. And if they've had cancer, if they've had congestive heart failure, if they've had depression, whatever it might be, those obviously increase the cost of insuring that person because they're probably going to be utilizing services related to those that can be very expensive. So their policies are often incredibly expensive. What guaranteed issue says is you can no longer underwrite based on individual health status. You have to cover those pre-existing conditions. And community rating works with it because it says you're not going to underwrite on that individual and determine their policy based on that individual. You're going to determine policies for a wide geographic area. The health of the community is going to determine what everybody pays in premiums. So no longer is the person with a pre-existing condition going to pay or have a quote of $30,000 for an insurance policy, and the young, healthy person is going to have an insurance policy of $2,000 a year. Community rating is going to equalize those. So it might be $10,000. I'm just throwing it out there. It's going to raise costs for young and healthy, or just healthy, and it's going to lower costs for people who are sick. The key is the mandate. The mandate says everybody, young and healthy, sick, frail, elderly, whoever, has to be in the insurance pool together. That's why they're mandating healthy, young individuals to purchase insurance, because they can at least equalize the insurance pool where you're spreading the risk among more people. I mean, let's face it, insurance works because you have healthy people paying premiums, not using services, sick people paying premiums but using services. These people subsidize the coverage and the delivery and utilization that everyone else needs when they need to see a doctor. So the mandate, guaranteed issue, community rating, all work together. So the government's saying, if you take out the mandate, you got to take out these other two. The states are saying, you take out the mandate, you have to take out everything. And interestingly, if you remember, when the Senate bill was passed, you remember when it was passed? Christmas Eve, 2009. The Senate bill was actually not meant to be the not meant to be the law of the land. The House had already passed a bill, Senate passed their bill. They were going to go to conference, iron out some differences, create a new bill, send that new bill back to the House and Senate. They voted on it, the president would sign it. If you remember, in January of 2010, Scott Brown was elected senator in Massachusetts, and he became the 41st Republican in the Senate. That was so big as far as politics goes, because what he did is he prevented the Democrats from ramming through whatever they wanted in the Senate. They had 60 votes up until that point, which means they could get over filibusters, they could get over procedural hurdles that the Republicans were trying to throw. But when they had 59 and Republicans had 41, that meant the Democrats had to pick up at least one Republican, and Republicans were unified in their opposition. So that meant that that House Senate compromise bill that was supposed to go back to the Senate would not have passed. No way was it going to pass. So what happened was the House said, well, the Senate passed their bill. I guess we got to pass it. That's the only way this passed. So the Senate bill then went to the House. The House passed it alongside what's called a reconciliation bill, which I know I'm getting into the weeds here, but it fixed a few things in the Senate bill. And then that's what was signed by the president. So the Senate bill was almost like a placeholder. It wasn't intended to be the law of the land, but that's what we got. The reason I mention that is because one of the key things the Supreme Court is looking at now related to severability is the fact that the Senate bill did not have boilerplate language that every bill that passes Congress usually has. And it's related to severability. It says, if one part of this law is declared unconstitutional, the rest of the law can remain. Usually that's in every other bill. It's boilerplate language. It's like fine print on a contract. They didn't include it. It was a drafting oversight, a drafting error, because they were frantically trying to get this thing passed. They knew it wasn't really going to be the law. They could clean it up afterward. Lo and behold, Scott Brown is in the Senate, and that's what they're left with. That's come back to haunt them, obviously, because the question is now, if the mandate is declared unconstitutional, can you take it out? The law itself is silent on it. It says, it doesn't say anything about whether one piece is unconstitutional, the rest of it stands. So there's an open question on whether the rest of the law can stand. Now, what precedent says, according to the court, there was a case about 30 years ago. It was a small financial services case, and basically it had the same kind of background where a law was passed, a provision was found unconstitutional, didn't have severability language, but the court said it doesn't really matter that it doesn't have severability language. We're going to rule that the rest of the law can stand. Now what people, at least what the opponents of law are saying, is that in that case, the provision that was found unconstitutional was fairly minor. It didn't even affect the rest of the law. What's different here is that the mandate is, I think, central. Not to everything, but it's central certainly to the insurance components of it. So knowing that, between the mandate and the severability clauses, what are the possible outcomes? Well, as I said before, the law could be upheld. Conventional wisdom actually going into the court was that, you know, why are conservatives wasting their time doing this? There was even talk about picking up Justice Antonin Scalia. And if anyone is a court watcher, or at least follows it a little, Scalia is by far, well, maybe not by far with Clarence Thomas, but he is a purist when it comes to the Constitution. This guy is as consistent as you will find as far as his interpretation of power and federal power, separations of power, everything. So they were even talking about picking him up based on something that he had written in a previous case. They were talking about getting Justice Roberts, or Chief Justice Roberts. So they were talking about a 7-2 decision. But after oral arguments, I think the conventional wisdom is this law is in trouble. But there certainly is the possibility that Justice Kennedy, who's the perennial swing vote, could side with the 4 more liberal justices. And I think if you saw during oral arguments or if you read about it, there was that ideological split. All of the justices appointed by Democratic presidents, including President Obama, were supportive of the law. All the conservatives seem to be adamantly opposed to it, including Justice Kennedy, but he's been a swing vote before. In fact, the one that people point to the most is his past decisions going back to the 1980s on abortion. He was a pro-life justice and judge. But when he had the chance in 1992, the first time that Roe v. Wade came up in a serious way before the court that could have been stripped or struck down, Justice Kennedy actually voted in favor of Roe v. Wade, even though his questions and oral arguments and all of the things that he had said before led you to believe that he would have voted to strike it down. So people wonder whether he'll do the same thing this time around. So it's possible the law is upheld. It's also possible that the entire law is thrown out. As I said before, there's questions around the constitutionality of the mandate. There's questions around whether the rest of the law can stand without it. A purist would say, look, if you have the heart of the law that is declared unconstitutional and there's no severability language, you leave no choice but to strike down the whole thing. It's possible. It's also possible that the mandate is struck down along with those two key provisions that the government, the federal government, is asking the court to strike down if the mandate is out. Guaranteed issue and community rating. So you could have the heart and soul of the law struck down. Or the last possibility is that the mandate alone is struck. So look at these four possibilities. These are leading possibilities. Look at the four leading possibilities. Only one has the law upheld. 3 out of the 4 have a scenario where something is struck down, ruled unconstitutional. So we're going to have some chaos no matter how they rule because, well, let's just go through them. So let's say the law is upheld. What does that mean? It means that implementation continues. We can go back to the wall charts. I should pull those up again. It means all 500 of those programs. It means all 2,000 powers, all 2,700 pages continue. There have been a lot of states, governors and legislatures that have refused to do anything really related to the health reform law because they've waited to see what the Supreme Court has said. The most prominent example is on insurance exchanges. These are the portals in 2014 where consumers can go through to find their insurance options, see what they're eligible for subsidies, see what benefits will be covered. Lots of states have said, look, we're not moving on these things at all. There have been a few that have said, we refuse to implement anything, even if it's ruled constitutional and the law continues. Governor Scott in Florida and Governor Jindal in Louisiana are two of the more prominent opponents. They've said, we're not moving on insurance exchanges at all because states are empowered to create these. The catch is, though, if a state doesn't do it, the federal government will come in and set it up for them, which in my mind, if you're Governor Scott or Governor Jindal, I would rather have a small bit of say in my destiny rather than abdicating it to the federal government. But that's very contentious, at least within conservative circles. But there have been other states that have said, look, we're not going to spend all the money and the planning and the time to put into exchanges, and then the court comes along, strikes down the whole law, and we're out the money. And we wasted our time. So Governor Christie, for instance, he just vetoed a bill that the legislature had sent him on creating an exchange. But in his veto message, he basically said, or at least inferred, that if the court rules that the law is constitutional, we may start implementing it on our own. Remains to be seen. But many states will start to move in that direction anyway. But you think about the political weapon that the law was in 2010 and could be in 2012 if the law is upheld. It's striking that the parallels between the health reform law and prescription drug coverage in 2003. If you remember, it was a huge battle. President Bush passed with a Republican Congress the prescription drug bill, Part D bill. In 2004, when they were up for re-election, they didn't talk anything about it because it was unpopular. And why it was unpopular, I don't know, but they were giving seniors drug coverage. I figured it would be something to run on. They didn't run on it at all because it was fairly unpopular, it was cumbersome, and blah, blah, blah. Same thing's happening now. You don't hear the president talking about this much. When asked, he'll talk about it. Democrats in Congress and candidates aren't out there talking about it, even though it does provide lots of protections and subsidies, et cetera, for citizens to get. It's probably because the public has been steadfastly opposed to this. You look at any poll. In fact, there was a poll, a CBS New York Times poll that came out the other day that said 58% of Americans want the law struck down by the court. Interestingly, they also support covering pre-existing conditions by a 2-to-1 margin. So I don't know if it's a disconnect. Supreme Court strikes it down. Covering pre-existing conditions is gone. But it was a political weapon in 2010. The Tea Party rode that wave of discontent and opposition, and they will certainly try and do it again, because if you think about it, if the law survives the court, there's only one more chance for it to be struck down. And that's through the election process and then going back into the legislative process for Congress to do something to take it. In 2013, before all those provisions come online in 2013, before they come online in 2014. So it certainly raises the stakes for the November elections. I would probably give this a 30% chance. Anthony Kennedy has surprised everybody before. But you have to look at what, if you remember watching CNN the day of the oral argument, or the first day of the oral arguments, Jeffrey Toobin, does anyone remember what Jeffrey Toobin said? He came out, and he was a supporter of the law, is a supporter of the law, and was saying, why are we wasting our time with this? He came out after oral arguments and said this was a train wreck for the federal government because 5 conservatives were staunchly against it, at least based on their comments. So I don't think that it's the most likely chance, but I do think it's a fairly significant chance compared to most of the other scenarios that it is possible. Second scenario, the entire law is overturned. What does that mean for health care? Well, it means the law never existed. It means we are winding the clock back to March 22nd, 2010, when there was no Patient Protection and Affordable Care Act. And if anyone is a fan of the book 1984 by George Orwell, they have a piece in there called The Memory Hole, where if Big Brother has something that they decreed or some projection that they put out there, and then it doesn't come to pass or it changes, they put the original into the memory hole and it wipes it out and it creates a new reality. That's actually what we have if the whole law is struck down. None of the provisions that have been implemented, the slacker provision, that's gone. Covering preventative services, that's gone. Closing the donut hole for seniors with rebates is gone. ACOs, those are gone, at least the statutory authority. So they're all gone. We go back to 2010, 2009, and that wasn't 2009 great? The system was working perfectly. We're going to be left with the status quo of back then, which everybody knows was broken. You may disagree with the fix and the treatment of the Affordable Care Act, but I think everybody agrees that the diagnosis is, and was, the system is totally broken. So we're going to go back to that and have to start over from scratch, which is a huge opportunity cost. Think of how long we've been talking about health reform. I mean, it goes back decades, obviously, but in current affairs, we've been talking about this endlessly since 2008. I mean, all the candidates, President Obama, Senator Clinton, Senator McCain, they all had their plans. It was, obviously going to be a big issue. And then from the beginning of 2009 until today, we've had a huge conversation on health care, which has been actually, I think, pretty healthy because we're actually talking about a broken system. How are we going to fix it? But if the law is struck and it's no longer there, we will have just spent 3+ years talking about a problem that we've now gone back to square one. And whether you're a Republican or Democrat, supporter or opponent of the law, that's a big opportunity cost. So, it's going to be a long time before anyone, if the law is struck and we still have a broken system, it's going to be a long time before we actually have the courage to go back and have this conversation again. Think of President Clinton in 1993 and 94. It took 16 years, took 4 presidential elections to get to talk about health reform again. Think of if this law is struck, 2028, by the time we get to talking about health reform again, that would be scary. But on a more tactical level, the lawsuits that would be unleashed would be unbelievable. So at Leavitt Partners, we put together these tabletops, we call them. They're basically scenario planning sessions. They war game out various things. We've looked at the development of exchanges. We've looked at fee-for-service and transitioning from fee-for-service to something that's risk-based or outcomes-based or performance-based. We've looked at a lot of issues. We actually looked at the Supreme Court and looked through some of these scenarios. One of the participants was a general counsel at Health and Human Services. This guy knows his stuff. And when we started talking about this scenario, he said, think of the lawsuits that are going to come. All of the reimbursement cuts that have been on the books thus far. I don't know if any of you have been on the receiving end of that, but there are tons, hundreds of billions of dollars in reimbursement cuts. Hospitals alone are on the hook for about $150 billion in cuts over the next 10 years. Home health, skilled nursing facilities, you name it, they probably got a cut. If the law is voided, it's not as though CMS is going to issue them a refund check. They're going to have to actually sue the federal government to recover that money because they will have been injured by a law that was declared unconstitutional. Think of the pharmaceutical industry. As I pointed out, they've already paid more than $5 billion in industry fees. They would have to sue to get that back. The federal government could actually come after and try and recover money. Think of all the grants they've given to states. Think of all the grants they've given and all the money they've given to nonprofits and others for various programs that they're creating and participating in. The feds could come and try and recover their money. And then somebody would countersue to say they can't get it. It would be a total mess. So even for someone who obviously is not a huge fan of the law, it would be a significant scenario if the entire law is overturned, and not a good one. But if you look at precedent, you look at everything, you look at the justices and how they've written and decided in previous cases, it's probably not the most likely scenario. They've been fairly deferential to Congress because conservatives, if they're fairly pure, they respect the separation of powers. And if they're a strict reader of the law with that severability clause, they may strike it down. But if they look at precedent that says, well, there is some case law that says we don't have to toss the whole thing, it remains to be seen how they rule. But I think the conventional wisdom is that it's not the most likely, but there still is a chance. Third issue is if you throw out the mandate, taking the government's request and throwing out guaranteed issue and community rating. Interesting thing, Justice Scalia, I don't know if you listened to the oral arguments, he basically said that would constitute a violation of the Eighth Amendment. And the Eighth Amendment is cruel and unusual punishment if the justices had to go through the law and decide what's connected to the mandate. Remember, it's 2,700 pages, so he figured that was punishment enough. But to say, here's the mandate, what's related to it? The government says these two pieces, but the question that arises is where does that stop? And in my mind and many others, it doesn't stop with those two provisions. The mandate actually touches and reaches these and more. So determining a subsidy is founded upon having everybody in that insurance pool, right? It also touches essential benefits because the mandate, remember, is requiring individuals to purchase a product, but the law also states what that product is with essential benefits. It also impacts the employer penalties because employers are going to be told what to offer. And if they don't offer it, they have to pay a penalty. The preventive benefits are all mandated. And anything related to insurance coverage in this law seems to somehow tie back to the mandate. And let's face it, the law was founded upon expanding coverage. So if the mandate goes, it touches a huge number of things. So interestingly, even though I think the conventional wisdom was if the mandate struck, an insurance market can't really work without those two provisions, community rating and guaranteed issue, of course they'll throw them out. Well, but if you look at it from a legal perspective, go back to what Justice Scalia said. Do you really want the court to go in and decide what's related to an insurance requirement and what isn't? I mean, I certainly wouldn't want 5 justices deciding how an insurance market's going to work. And I don't think, since these are conservative justices, they typically restrain themselves, judicial restraint being the buzzword now. And typically they take a fairly strict reading of the law and would say that is an area for Congress to figure out. That's not our place to go through and decide how an insurance market's going to work without a mandate. So I think precedent says there's been actually no precedent where a law was struck down or a provision of a law was struck down and the court went in and decided what was attached to it. It's never happened before. So most people think it won't happen this time, and I agree with them. Which actually brings us to the last scenario, which I think is the most likely scenario. And that is that the mandate by itself will be found unconstitutional. You just look at the questions, you look at precedent, you look at everything. It kind of leads you to this determination, into this conclusion. So what happens if the mandate is pulled? Well, it will have a pretty dramatic effect on the market, because the way that the insurance provisions work is that you have basically two markets. You have individual and small group, and then you have large group. So more employer coverage, large employer. Individual and small group, highly regulated. That's where the provisions for guaranteed issue and community rating are applied. If the mandate is there and those two provisions are, if the mandate isn't there and those two are still left, that means insurance companies are going to have to provide care to individuals who have lots of chronic disease, can sign up for a policy whenever they want, they can't deny them. They will only collect a certain amount in premiums because, again, it's going to be equalized among the community. So they are going to take a bath covering the individual and small group market. They're going to lose their shirt. What happens in the large group market in that case? You guys know about cost shifting fairly well, I think, between commercial insurance, Medicare, and Medicaid. It's going to happen in this market as well. Insurers are going to lose a ton of money in the individual and small group market, and they're going to have to make up for it in the relatively unregulated market, where there isn't guaranteed issue and community rating. It's going to explode costs in the large group employer market. That doesn't sound like a very rosy picture, particularly on a beautiful Saturday morning. So what happens? How can we prevent that from happening? Because you have to think, if the court strikes down the mandate, they're going to kick it back to Congress and the administration to figure out, which is what I think will happen. Will they try and delay to try and find a compromise and some way to fill the hole? Maybe. They could try. Some people say, though, that the administration would be loath to delay implementation at all because they want this thing to take effect as soon as possible. They want the benefits out there as soon as possible. It's like planting a seed. You know, they want it to grow as quickly as possible, and by delaying it, it gives the opposition more time to come in and try and muck up the works. So they may not delay it. And there are also requirements in the law itself that these provisions have to take effect at certain times, mostly in 2014. Legislative solution, do you think that Republicans are going to try and help the president out of this bind? Is there anyone who thinks Republicans will try and help the president out of this bind? They're not going to lift a finger to help him. So if he's reelected and you have the law in place but no mandate, they're going to just let it ride. They're going to say, have fun with that. Try and figure it out. Brings us to what Justice Kennedy, I just think based on what he's written, what he said, his view of the separation of powers and the role of government, I can't for the life of me see him saying, yes, the Congress has the power to require us to buy a product, because it's the slippery slope. That's what the court always looks at. How could this be used in the future? You know, they're looking at a court case from the New Deal on wheat production. You know, that was 80 years ago, and they're citing that. So 80 years from now, we could be talking about this particular case and what they decided. So Justice Kennedy, I think, will not set the precedent for the federal government to really have almost unlimited power through the Commerce Clause. So I think this is what's going to happen. That brings us to politics, because if that is the scenario that plays out, there is going to have to be some kind of approach to fix it. Because as I said, I think that that really would happen between the small and individual group markets and the commercial markets. We would have an explosion of costs. And employers are already hemorrhaging under, and even in your own businesses, you probably know that. So somebody's going to have to fix it, and that brings us to the elections. Who's going to be there to try and fix it? The House of Representatives, the Republicans have about a 30-seat majority. Democrats would have to pick up an unprecedented, at least as far as presidents running for re-election, unprecedented number of seats to take control. So Republicans are likely to hold. The Senate is where all the action has occurred, both with passing the bill and with what I think will be an effort to fix it. Currently, Democrats have a majority, a 3-seat majority. For them, though, they have a huge mountain to climb, because if you think back to 2006 and what happened in President Bush's second midterm elections, he lost the House, he lost the Senate. We had Speaker Pelosi, Majority Leader Reid. They had a huge tsunami in 2006. They're now defending all of those Senate seats that they picked up. So a third of the Senate is up every 2 years. And so their term is up now, those senators that won in 2006, which means that Democrats are defending 2/3 of the seats that are up. And if you were a senator, would you like to run in this environment with not only the health reform law that you probably voted for, but unemployment, debt, deficit? You know, you look at the environment, the political environment for someone to run, and it is really tough. So to be an incumbent running is going to be very difficult. So they're defending 2 out of 3 seats. And Republicans need to pick up a net of 4 seats to take control of the Senate. And if you look at the toss-ups right now, there are 7 toss-ups: Nevada, Missouri, a couple of other ones, obviously 7 of them. Democrats are defending 5 of those. That means they not only have to win all of the safe seats, they have to win almost every single one of their toss-ups. Virginia's another one, where we are now. Highly unlikely. In my mind, I think the Republicans are going to pick up the Senate as well. So it leads us to what happens with the presidential race. It's possible that the president will win. It's a very tight race. It's unlikely that the Republicans would take the Senate and the president would run re-election. I think if you look at those 2 things, most people, pollsters, would tell you if Republicans win one, they're probably going to win the other. And there's probably no scenario where Mitt Romney wins and then Republicans don't take the Senate. I think that's the most unlikely. So just to look at a couple of scenarios, if the law is upheld and you have President Romney, but Democrats actually keep the Senate, unlikely but possible, President Romney would actually look to what he could do administratively to either try and gut the law, delay it, stop it, however he can. But since you have a Democratic backstop in the Senate, you're going to have the law run its course, most likely. Implementation will be different because you'll have the administration writing, the Republican administration writing those rules. But implementation will continue. That's telling me I should not continue. But I'm almost finished. If you have, this is the most interesting one to look at. If you have a Republican president, Republican Congress, what do if the law is upheld? They have said very clearly they're going after this. They're going to try and repeal it, which I think is impossible due to the Senate procedure. They will then try and use budget reconciliation. I mentioned it before. That's a bill that basically allows them to go after anything that has money attached to it. So they can't go after insurance provisions and preventive services and anything related to that, but they can go after something like Medicaid expansion. That's hundreds of billions of dollars. They can go after subsidies, which are hundreds of billions of dollars. They can go after taxes. They can go after industry fees. Anything like that, they can use reconciliation to go after, and you only need 51 votes in the Senate to get it. So that's very likely, and they will have a very short window to actually do this, but I certainly think that they will try. If the mandate only is overturned and this is what you have, they may try and delay. They may have no choice. They may try and find some compromise, but again, Republicans don't have any incentive to try and help the Democrats fix this. However, if they have a sweep and the mandate was overturned, Republicans are going to be in control of the levers of power. And so the fallout is actually going to come on their watch, even though they didn't want this, didn't ask for it, but they're going to have to clean it up. So they may try and repeal it, probably won't happen. They may try reconciliation to gut it and basically hollow it out so it's a shell of what was originally passed. Or could they try and fix it? It's possible. Not likely, but it's possible. So you have lots of interesting things happening here in Washington. I think the key takeaways are that the fate of the law really is at stake. Over the next, you might even be in town when the Supreme Court rules. But in the next couple of weeks, we're going to have, I think, a definitive moment where the fate of this law is either going to be, it's going to survive, it's going to be killed, or it's going to be severely damaged. And each of those, as we've seen, has pretty significant repercussions. If the mandate itself, or related provisions, or even if the whole law is tossed, it is going to be totally chaotic. So you think the waters have been choppy thus far, it's going to be incredibly choppy. And unfortunately, we're sitting here and we're on the receiving end of it. So very little that we can do. We can certainly talk to our representatives like the previous folks were talking about. You can certainly try and influence it, but at the end of the day, we're sitting here and we just have to almost wait and see what happens, which is unfortunate. But it certainly is a fascinating year. You have not only the court, you have the elections, presidential election no less, and at the end of the year, they have what's called Taxmageddon. Has anyone been following this one? It's when the Bush tax cuts expire. It's when the Social Security or the payroll tax cut expires. We have a debt ceiling vote coming up again, probably early next year. Sequestration of those automatic cuts that were included in the last debt ceiling deal. All those SGR, you guys are facing a 30% Medicare cut on January 1. That's going to be a fix of tens of billions of dollars. So you have all those things coming to a head at the end of this year. Throw in the fact that they may have to try and fix the health reform law. It's just a fascinating, if you're a political junkie like me, this is great stuff. I'd pay tickets to see this. But at the end of the day, you're the ones who are on the front lines, which is unfortunate that you have to deal with this stuff. And this has nothing to do with delivering care. Now, that's another area that I've spent a lot of time on, the delivery of care and health IT and some other things. This stuff is so foreign. There's no partisanship in how you deliver care, right? We know that system's broken. We should be focusing on fixing that rather than going back and trying to clean up the mess from previously. So with that, I'll give my official disclaimer and welcome any questions you might have.